first speaker, and by the way, you probably noticed, we'll go through later, but apart from this first presentation, each topic session, of which there are 6, is pretty much the same. There's a overview presentation, discussants who are really not respondents. They can respond, but they also will tell their own stories, and then facilitated discussion for about a half hour. And in those facilitated discussions, we really want you to be succinct. So this session, the first speaker is Rylin Rodgers from Indianapolis. I purposely asked Rylin to come. She's a family representative because, as I think everyone in this room appreciates, taking care of kids with complex conditions is really a family endeavor. And I really wanted to anchor our whole meeting, if we can, to remember that that's the case, and invited Rylin to kind of just give an overview. I said she's speaking to the choir. She doesn't have to start at the very beginning on this, but I think it's important to try to establish that theme as we get started. So, Rylin?
So I'm delighted to set the stage for our time together. And for the next few minutes, I invite you to listen to my remarks and forget who I am. Instead, think about the hundreds, thousands, tens of thousands of families I represent. Think about the children and families who most influence your work. It is for those families and for the new children born each day with a complex healthcare need that our work together over the next 2 days matters most. Our work requires dedication to partnership with families at all levels. I'm here today because of this moment. My son Matthew and I, 18 years ago, hours after his birth, when I first knew that I had a child with special health care needs, a child with health complexity. I knew in this moment that if he lived for more than a few hours, my family and I were jumping into a whole new world. In the long days that followed that picture, I found myself at the library of our local children's hospital trying to understand this new world. And because we all benefit from those that go before, it was a bit more than luck that led me that day to the story of Katie Beckett, a child who was living with health complexity at a time when children with medical complexity were forced to live in hospitals and institutional settings because Medicaid did not cover their care at home. Katie's family fought for and won changes to the Medicaid program that allowed for her and children like her to play, grow, and learn at home where they belong. I learned by reading about Katie's family that I would be able to take Matthew home all along with his very heavy load of medical equipment. I also learned that by their example, that if I ran into a problem with the systems and services that were in place to support him, I too could change the federal law. Thank goodness for those lessons, because the reality of health policy on that day 18 years ago and of health policy today is that it does not yet meet the needs of the people in this picture or the hundreds, thousands, tens of thousands of families like them. Matthew was born at the perfect moment to have a childhood totally impacted by health policy. His birth was 4 years after the Clinton health care plan imploded, 15 years after Katie Beckett made changes that allowed children access to their community, and 1 year before the definition that we use today for children and youth with special health care needs was established. Our family fell into the pre-Obamacare gap. Uninsured after reaching our lifetime limit, which was while he was in the NICU, waitlisted for Medicaid waivers, heart-wrenching options were weighed, painful choices were made, and medical debt was accumulated. September 23rd, 2010, a very important day in our family. 6 months after the passage of the Affordable Care Act marked our return to our insurability, and it transformed our socioeconomic status and dramatically widened Matthew's options for adult life. Today, he's experiencing the transition to adulthood and to a healthcare system that is once again transforming, this time via integrated care. For Matthew, his sister Laura, our family, and every family raising a child with complex healthcare needs, policy matters. It touches our lives every day, and frankly, it doesn't work for us. These families are and will continue to be the canaries in the coal mine of the American healthcare system. We must pivot from trickle-down adult population health and return to building on the lessons of these families. They are our best guides for a reworked and reformed healthcare system in America. We all live and function in an ineffective world of labels, diagnosis, access points, and eligibility. The intention of labels, tiers, and access routes is good. We want to get children and families the care they need. The reality, however, is it doesn't work. In my mind, the tension is how can care systems and sorting, which are designed to weed out variability, meet the unique complexities of individual children and families? I remember so clearly being in the NICU after my now 15-year-old daughter was born. Now I had 2 children with special health care needs and no named diagnosis. I saw a mom across the way who had a child who was born with Down syndrome, and thus she had a welcome bag from the Indiana Down Syndrome Group and a clear plan for post-NICU care from developmental pediatrics. I wanted a bag, I wanted a diagnosis, and I wanted a plan. It was several years before we got a named diagnosis, mitochondrial myopathy, but the plan and the path wasn't clear, and it still isn't clear. In my work with families for the last 18 years, I've learned that no path is clear, even those that come with a bag. Care, financing, and support systems are in a constant state of change, and no one entity outside of the individual family is effectively integrated into all aspects of a child's life and needs. But that's not to say we should stop trying to assess risk and tier care to meet children's needs. I know that being Matthew's sister saved Laura's life. Her health status has generally been more fragile, and the care team that had first considered the issues for Matthew was able to avoid several potentially life-ending choices for Laura. A tiered care system allowed my children, the clinicians, to understand and meet the complex needs of my children. We must work in all settings to learn about the complex children whose care we deliver. We must stretch our thinking beyond the focus of our individual care expertise. We must work collaboratively to change systems so there's no wrong door to care. But who do we really mean when we say kids with complex healthcare needs? In my family, we would say not the white limo people. My husband and I observed a white limo pull up to the front door of the hospital when we were with our infant son on day way too many of yet another hospital stay. A family got in to go home. The backstory from a nurse is that the child had had a successful surgery and a long recovery and was now 100% healthy. The family was celebrating the fact that they were done with special medical care with an over-the-top splurge of the limo ride home. My husband and I looked at each other and immediately declared that when this was over, we too would take a limo ride home. But for our family, and for hundreds, thousands, tens of thousands of families, the limo ride never came, and it never will. That's what we mean by complex healthcare needs. Not simple short-term treatment with a clear finish line, but a lifetime of ongoing complicated care. At this moment, care coordination is the promised magical solution for hundreds, thousands, tens of thousands of families. And with so much promise, we cannot let this moment pass. It will take hard work and perhaps a bit of real magic to ensure that what is provided to families meets the definition and follows models that provide real care coordination, not utilization management, not a list of outdated websites, and not a room down the hall. This does not mean one type or one location. Instead, it means access to care coordination within the system providing care for the family. It means care coordination that moves with a child and family across the life course and across care neighborhoods. It means care coordination that meets the family where they are and recognizes they are the sole constant in their child's life. Is team-based care coordination really magic? Could a shared plan of care support the months following a new diagnosis? Could it ebb and flow during transition? Would it guide a different team during a crisis? Could it be the safety net in our giant gaps of systems? Will it ensure that mental health is a part of care? Can it empower children to become the youth that self-manage their care? I believe so, but only if it's family-centered. We must speak up together and not miss the promise of this moment. Matthew, having developed chronic pancreatitis this year, is navigating with us a new care need. Timing being everything, this is happening as he works to transition to adult care providers. In a recent meeting with a prospective adult primary care provider, Matthew summed up his recent multiple-week ICU stays with, if in 2015 you're in the hospital for over a week, you're pretty close to dead. The primary care provider did not share our family's view on gallows humor, and thus was not the right choice for Matthew. But the quip was true. Shorter hospital stays, strong limits on home nursing support, and shortages of providers mean that families are managing complex healthcare needs out of the hospital and with minimal support. And geography matters too. My middle-of-the-nowhere rural Indiana home has meant no reliable access to home care, as well as the reality of being one scary hour's ride away from quality hope. And don't even get me started on blizzard season. Often this is a good thing. My mom training to access ports, suction, assess needs, and adjust medication has meant greater access to life for my children. Cars are purchased for their features as rolling medical centers. Just-in-time interventions are provided at school, 4-H, Target, church, extracurricular activities. And as they've grown up, my children have taken on huge chunks of their care, scheduling appointments, pre-planning medical supply delivery, and Laura has me in awe at her ability to self-access her port. This is the true reality for hundreds, thousands, tens of thousands of families. They are carrying out health care in their communities, and it's time-consuming. It's often taxing, physically and emotionally exhausting. We must work together, families, children, clinicians, care teams, to maximize skills and independence by providing the support needed to self-manage effectively. And we must meet families where they are to support and enhance their unique capacities. Caring for children with complex healthcare needs takes a team. Multiple specialists, primary care providers, related service providers. But our healthcare system does not work that way. Even when team care is available, the child's needs have to fit the team instead of the team fitting the child. I have often worked with families who are wistful for a new challenging diagnosis, as it would grant them access to the team model of care their child needs. What a symptom of brokenness. You have to have the right kind of medical complexity to work with a team. It is family leaders dedicated to keeping children at the heart of healthcare who've been able to articulate the needs for co-management and team care. We hear them at the family, state, and national level, painting a picture of what is needed and what is possible. Laura developed a new mobility issue this fall, and her first stop at primary care led to a referral to rheumatology, and a lot of eye rolling at adding yet another specialist. The additional advice was to walk less and use her wheelchair more. The first available non-emergency rheumatology appointment was 6 months out. 6 months of limited movement seemed likely to head us in the very wrong direction. An email to the wife of a colleague who happened to be the head of rheumatology netted two options. One, a same-day appointment. But it was the second option that mattered most. The colleague's wife talked to Laura via email about symptoms and issues, and together they created a physical therapy plan that started that week. We avoided yet another appointment, delayed care, and further mobility complications, all because of our own ad hoc team care. I'm aware every day how privileged my children and I are. But what really matters in this story is that we must figure out how to get this to work for the hundreds, thousands, and tens of thousands of Lauras. It should not require special connections and personal favors for a child to get the care they need when they need it. And our physician partners share this wish. They too need a system where child-focused team care is possible. Healthcare financing is my favorite topic, honestly. We all know the numbers. Americans spend more on health for less quality than almost anywhere else. And I know the end user experience of what remains a very broken healthcare financing system for hundreds, thousands, tens of thousands of families. We are the family for whom medical expenses exceeded our income, for whom affording care and food was a challenge. Then we were the family for whom the legacy of medical debt touched every moment of our lives. And now we're the family that even with a Cadillac private insurance and Medicaid waivers still faces substantial out-of-pocket costs. Too often, medical providers are buffered from the understanding of the true cost of care. And frankly, who can blame them? The different charges for the same services create a very confusing web. But providers, like families, know that there's not currently enough money to provide what is needed. The truth is, quality care costs, but the investment is worth it. Keeping children and families at the heart of healthcare financing decisions at all levels is the only way to have an American healthcare system that works. We must raise our collective voices and votes to advocate for a system that works for families, that guide our efforts today, tomorrow, and every day. I'm honored that my life and my life's work have allowed me to learn from and with families, clinicians, and care teams all over America. And I know that it's our joint perspective and passion that will move us forward. It is the only way.
Thank you for that moving orientation to the conference. I think it got us all in exactly the right focus of where we should be spending our energies and keep us with patients and families at the center of our attention throughout the rest of the conference and throughout our deliberations. So thank you very much. My name is Charlie Homer. I'm pleased to be chairing or facilitating this panel, is I guess the appropriate language. The focus of this one, a perfect follow-up to the stage setting, is on national health policy. And as Ed articulated, Cindy Mann is going to kick us off. As a speaker, we'll have several discussants. We have, be followed by David Keller and Carolyn Langer. All of the bios are in your handout, so I won't be giving you detailed, or in fact, any additional bios beyond what I've already given you. So with that, I'll hand it over to Cindy. And again, if you're here as the clicker, if you'd like to do it from your seat, fine. If you'd like to do the podium, that's also fine. Either, whatever you're more comfortable with.
Great to be here and to open up this symposium following, I think, what was the perfect introduction to the symposium activities. If it takes a village to raise a child, it certainly takes a very dedicated and thoughtful village to help support and raise a child with complex medical needs. So I appreciate the mix of folks in this room, certainly most notably families themselves, as well as caretakers, policymakers, researchers, and because it really does take a village. So I wanted to set the stage a little bit from the perspective of policy, and thank you for noting, Linda, that policy matters, but I would be not the first to say that it's necessary but hardly sufficient. And I think that's part of what I want to talk about here is what are the policy dimensions that surround our ability to provide the right care system for kids with complex medical needs. And where does the policy fall short, and where does the policy, while looking just fine on paper, not in fact translate into the kinds of systems and care that kids need? So I'm going to start with coverage, because while it is taken for granted, I think that kids with complex healthcare needs have healthcare coverage. It's not always the case, and I want to at least touch upon that set of issues. So the good news, of course, as everyone knows, is that we've made enormous strides in terms of covering children. Medicaid, with its companion program, CHIP, has really made it possible for us to see the data that we see on the right side of this slide, which is that the uninsurance rate for children over the 2013-2015 period, what we've seen in the last quarter is that we actually have an uninsurance rate dipping below 5% of all children. My colleague, Jenny Kenny, who does so much of these data analysis and who I've been joined at the hip with for many years in terms of looking at these questions, tells me it is too soon to have the celebration about 5%. We've actually gone below 5%. We need at least another quarter of data. But it's a remarkable change that's happened and a remarkable advance. 5% is too much. We need to get 100%. But it's a major step forward. And we see the importance on the left side of public programs as a mechanism for coverage. We also know, of course, that the Medicaid program has changed its very nature as a result of the Affordable Care Act, partly because it now anchors a new coverage continuum in this country. So we have a mechanism for covering people who do not have affordable health care coverage, and that mechanism is supposed to not be siloed between in Medicaid and then siloed in CHIP and then siloed in the exchange, but it is really intended to be a continuum of coverage, which is what this depiction is intended to represent. Sadly, we have a gap on the left side of this continuum because I'm sure, as everybody knows, the Supreme Court determined that while the ACA, the Affordable Care Act, was fully constitutional, the one aspect that it struck down was the Secretary of HHS's authority to penalize a state if they didn't take up the Medicaid expansion, which was a roundabout way of essentially making that expansion voluntary with states. There's a lot to be said about that expansion and where we are. We have 30 states plus the district that have, at this point, taken up the expansion, and hopefully we will continue to see more states join. But it's an important component to remember through the lens of children with complex medical needs, because in many cases, if their parents are low income and they're living in the 20 states that have not expanded, the parents themselves are struggling with lack of health insurance coverage. And that creates its own pressures, strains, and certainly risks for the health of the parents, and therefore for the health of the children and the family well-being. So we can't forget, I think, that gap in terms of our focus on children with complex medical needs. Beyond the issue of expanding coverage, it's important to note, particularly for this population, that the Medicaid program and the CHIP program and the marketplace were changed dramatically in terms of enrollment and retention procedures. And that is important because one would think that a kid who's on Medicaid with complex medical needs would never drop off that Medicaid program. Their situation is usually pretty stable. And why would there be a change in insurance? But sadly, we do see We do see churning in the program, and we do see kids who are clearly continuing to be eligible get dropped off the program, and not only have to deal with the day-to-day struggles of getting the medical care that they need, but also then getting payment and getting back into coverage. The good news is that the law creates new systems for retention, new systems for simplification. The goal, of course, is never to have an eligible person who's not enrolled, and never to have that person lose coverage for as long as they are eligible. So there's lots of systems and new rules put in place to promote that. Not all of those systems are working exactly as they are intended to. States are still developing and perfecting those systems, so we're still moving forward on that terrain. But I also want to point out that as much as the ACA lifted all boats in terms of eligibility, enrollment, and retention simplification, there are still options for states and communities to do more, and some of those are listed here in terms of ways that states can simply take the burden off the families, which is particularly important for kids and families with complex health care needs. It is the perfect population for states to focus on really doing automated eligibility renewals and really not needing to reach out to the family except for maybe to confirm information when it's not otherwise available through data systems. I also want to mention, just because I've got a captive audience of interested people, that I've long thought about. Nobody's yet come forth with this, so I'm happy to work with anyone interested in it. Long thought about states looking for waivers for kids with complex medical needs to say, you know what, we don't have to do annual redeterminations. Their situation is going to stay stable. Let's keep them on the program for 3 years, for 5 years. We'll do different kinds of checks to make sure they haven't moved to New Jersey, if you aren't in New Jersey already. There's lots of ways to deal with it. I think it's an area that is ready to happen. I can't promise anything. I'm not at CMS anymore. But I do think that we're not done with the revolution that has happened in terms of enrollment and retention, and there's yet more to be done. So let's turn to a focus on the needs and how well those needs have been met for kids with complex healthcare needs. So as was noted, there's lots of definitions floating around, right? There's kids with special health care needs, there's kids with complex health care needs. It is helpful to have that differentiation for a variety of reasons, and to also see how well we're doing for kids, although, as we all know, those lines are pretty fuzzy. And for any given family and any given child, it's sometimes not easy to know which side of the fence they're on, or not necessarily terribly important to know which side of the fence they're on. But for purposes of at least understanding where we are, estimates are that about 20% of the kids in the United States have special health care needs, and about 60% of those children have what's been considered to be more complex health care needs. We have definitions here that you'll see in the slides that I'm not going to repeat, but we have kids with complex health care needs represent 34% of the spending on children. I think we're all used to seeing the famous, I think Kaiser Commission on Medicaid and the Uninsured began at the slide that shows how kids represent such a large segment of the Medicaid population, but such a small segment of the spending. That is true, but when you focus in on kids with complex health care needs, of course, they are high-cost kids. But they're getting lost in some respects on the focus of healthcare costs and what we can do to bring down healthcare costs, because they're within a larger population of kids who largely are not terribly expensive. Whereas often kids, adults with disabilities, adults with chronic health care are in separate eligibility categories and somehow are spotted more easily in terms of Medicaid eligibility data. And therein lies one of our problems, which is less focus on kids with complex medical needs and the systems around them in the state Medicaid agency level. More focus on adults, not, of course, for any bad reasons, but simply because they get lost. Those kids get lost often within the data of healthcare kids more generally. Not surprising to any family with a kid with special health care needs and complex health care needs. 40% of the spending for those children, for the Medicaid spending for those children, is tied to hospital care. Only 2% is tied to primary care. And one of the big questions before us is how do we switch that balance, and how can we persuade policymakers and budgeteers that in doing so, it is not only good for families, good for children, good for society, but good for the bottom line in terms of shifting a focus on to getting kids out of hospitals as much as possible. This is the depressing part of the slideshow, I think, for me anyway, and for families who live with it every day, which is that in today, where we've had advances in care management, where we've had advances certainly in policy, we still have so many children with special health care needs and kids with complex health care needs who have unmet needs, the figure on the right side of the slide shows that 44% of kids with medically complex conditions identified as having an unmet need. So we also have some specific groups of kids with complex health care needs, and sometimes it's really important as we think about the population to think about these kids separately. They tend to be in separate systems. They tend to have particular kinds of problems. Certainly they have additional problems I have found with continuity of coverage because their family situation is not necessarily stable, or their connection to their family is not necessarily stable. And if you're in the foster care system or in a justice-involved situation, you are almost by definition in a very dynamic, shall we say, situation where often your medical records, your medical needs aren't passed on from one situation to another. So I just want to call out kids in foster care. There's about 400,000 kids in foster care nationally. Many of them are kids with significant health care needs. And including behavioral health, mental health issues, but also physical health issues. Similarly, for justice-involved children and youth, there are a little under 80,000 youth in the juvenile justice system, although those numbers are really hard to pin down because definitions, again, are somewhat fuzzy. And again, most of those children, not surprising to anyone in this room, are kids with complex health care needs and special health care needs. So why is this all happening? Why do we have so much unmet needs? I think that's for all of us to be exploring over the next day and a half and to think about solutions. Let me start with, again, the law, and to remind us that the law in the Medicaid program with respect to basic physical and mental health care needs could not be more strong. It is known as the Early and Periodic Screening, Diagnostic, and Treatment EPSDT benefit. Rolls right off your tongue. And it is applicable. Of course, kids grow up, so part of the problem is kids grow up. That's the good news. But EPSDT goes to for individuals who are under 21. But let's concentrate on the words on this page, because everybody here, hopefully, is very familiar with EPSDT. Because it is really the foundation for trying to address this question of unmet health care needs. It is intended, and it's been in the program for many years, it's been strengthened a couple times by Congress, but it is certainly not new. It is intended to assure the early identification and treatment of health issues for children, right? So one issue for kids with complex health care needs is early identification. And it is intended to provide all, and I've bolded all, treatment services that a child needs as long as Medicaid could cover that service under the law, even if that service is not available, not covered in that state for an adult. So for those of us who know Medicaid policy, you know that state Medicaid programs get to pick and choose a bit on their benefits and their structure and the amount, duration, and scope of their benefits. And they do that, and then it's for often managed care plans or others to manage utilization and to determine the medical necessity of those services and whether Medicaid will pay for those services. But the rule in Medicaid is very different. The rule in Medicaid is that all treatment services that are necessary for that child must be provided if it is the kind of service that Medicaid could cover. So that state plan limitation for benefits, not applicable to children. Not applicable to children as long as it is a service that Medicaid could cover. And if I could, I'd probably tattoo that on almost everybody's arm so that we'd have it with us at any moment in doubt whether, is that going to be covered for that child? Oh, no, let me check my EPSDT tattoo. It is absolutely going to be covered for that child. And I want to also point to the last bullet, which is that the definition of medical necessity for children in the EPSDT program, in the Medicaid program writ large, there's nothing special about EPSDT, it describes the Medicaid program writ large. That definition of medical necessity is also broader than the definition of medical necessity for adults. It is to correct or ameliorate defects of physical and mental illness. Many times we'll see Medicaid agencies say, or managed care plans say with respect to an adult that's not going to cure them. That's not going to make a difference in terms of reducing the extent of the illness or the chronic or the disease. That is not the standard for medical necessity for children. So the law could not be more strong, yet we saw in a couple slides ago that we have kids with unmet medical needs, unmet healthcare needs. So where's the disconnect? It's, again, for all of us, I think, to bring in our experiences to understand that. One part of the disconnect is it isn't tattooed on our arms, and we don't always, and practitioners and even Medicaid agencies, and when I was at CMS, we actually reissued a manual about EPSDT directed to Medicaid agencies, don't always know what EPSDT requires. Second issue is that the basic services in the Medicaid program that could be covered for any child isn't everything that a kid with complex healthcare needs. And we talked about waivers and waiver waiting list. There is in the Medicaid program certainly the ability through home and community-based service waivers, Katie Beckett waivers, and others to get other services for a child that will help that child flourish. Yet some of those services are not required under the Medicaid program and are special services. So not all of those services can be accessed through EPSDT. Sometimes you have to be on a special waiver to get the waiver services. And at this point in our story of healthcare policy, those waiver lists can be, you can have waiting lists for those waiver services. And thirdly, and I think this is a lot of what we're all going to be talking about over this day and a half, is our systems of care are not necessarily designed in such a way to assure that all healthcare needs for kids with complex medical needs are met. I'm not going to go through these examples, but I do want to point out that there are many efforts underway around the country to really bring together the kinds of things that we just talked about a minute ago. The kinds of care coordination services, the kinds of teamwork and integrated case management that kids with special health care needs to meet their needs. So here are a couple examples. I'll just touch upon a few things. Here's one. These are the next 4 examples in these slides are all projects from CMMI, which is the Centers for Medicare and Medicaid Innovation. So we have one in the University of Illinois. I spotted it particularly because it is about a medical neighborhood, and it is bringing that care coordination to kids where they live, where they work, where they attend school. It's getting it out of the doctor's offices, getting it out of the hospital, getting into the neighborhood, and getting into the team with the benefit also of embedded navigators. We have one in Boston Medical Center over here described, and they are developing and have for each family a family navigator. Has noted care management is really important. I would argue, however, that we have to be really careful that care management is focused and is the care manager owes their allegiance to the child and to the family. All too often, I think all of us have experienced this with any family member with complex medical needs, whether a child or otherwise. There's a care manager for the hospital, and there's a care manager for the health plan, and there's a care manager for the rehab center, and there are care managers all over our system. But A, they're not talking to each other, and B, they are often representing those institutions as opposed to being a person-centered, a child-centered care management system. So yes, I truly believe in the opportunity for care management to make an enormous difference, but we really have to think about what care management means and whose allegiance the care manager is connected to. Let me just mention a couple other beyond the CMMI. Just want to make sure we have time for other folks. New York State is developing health homes for kids with complex medical needs. There's several states doing that. I want to mention particularly health homes. It is a provision in the Affordable Care Act. I mention it because, not so much because it's unique about trying to pull together a team approach and a system of care for kids with complex medical needs, but because it provides 90% federal matching for the care coordination services. You cannot, under the federal law, define health homes just for kids versus for adults. So you have to do a little bit jiu-jitsu in terms of making it work. You can define it by conditions. You can define it by providers. And CMS, I think, is very interested in working with states to be able to support health homes that bring in that 90% match and their focus on the issues of kids with complex medical needs. And of course, I just want to mention institutions themselves are also looking at ways, and this is an example from CHOP in Philadelphia, looking at ways to develop care management programs and a network of care in and outside of the hospital for kids with complex medical needs. I want to especially call attention to the issue of behavioral health integration. It is sadly not the reality in so many of our communities for kids, for adults. We have built up over the years, for financing reasons largely, a behavioral health system over here and a physical health system over here. And the good news is 5 years ago you would talk to a state or a health system provider and they'd say, I'm doing really integrated care management. And I'd say, what about behavioral health? And they said, well, not that, right? So mostly nobody says that anymore, right? They do say that with respect to long-term services and supports. They forget that. But behavioral health, there's a lot of struggling around making it work. And it's an area that we need to pay a lot of attention to for our kids with complex medical needs as well. But there's a lot of energy, a lot of interest going on all around the country about that. So let me stop there so we have time for just other panelists and discussion. Bottom line here is that kids are not getting, I think, the focused attention that other people with complex medical needs are getting in our system. There's quite a bit of interest, quite a bit of focus on how to construct systems of care for people with complex medical needs. Sometimes under the label, which I don't love, of super utilizers, and people have different labels for it, but so often kids get lost in that package, and as we all know, kids need some special attention and special kinds of services around them to make those systems work. So we need to make sure that our health systems and our policymakers, both at the state and the federal level, make sure they understand who these kids are and what systems needs they have. So thank you.
So let's see, somewhere in here should be some slides with my name on it. So I was asked, thank you, Ed. Well, actually, I was scared to death when Ed told me that I had to respond to Cindy Mann. So I wanted to share with you my initial response. Can I get an amen? Wow, that was a tour de force. I think what I wanted to a lot of what I'm going to say echoes what Cindy just said, although when you're reviewing a slide set, you can't tell exactly what someone's going to say. But I think we're going to be really coming from the same page. I think the perspective I want to bring is from somebody who's now worked in 3 different states over the last 8 years trying to do this work and see how this policy plays out when you move from federal policy into each of the states. I was privileged to work in the state Medicaid office, actually for Carolyn Langer, in Massachusetts for a few years. I worked with the Office of the Health Insurance Commissioner in the state of Rhode Island for a few years on their health reform efforts, and now I'm pretty heavily engaged in work out in Colorado on this same area. And I think from that point of view, as a practitioner who sits at a lot of these tables, I can tell you there's a lot going on, but everything Cindy just told you is true, and except it's also happening at a state level as well. So the first, and I start, every time I talk to a group of pediatricians, I have to start by saying, right now Medicaid policy is not focused on kids, it's focused on adults. And it's focused, and there's good reason for that. I mean, I don't hold Medicaid responsible for that. They have been handed a brand new population that they have to take care of because children have been in Medicaid for a long time. But for a lot of adults, Medicaid is new, and the expansion of Medicaid is a big deal, and they're trying to figure out how it's done. Most of our state Medicaid agencies are strapped for time and resources, and they have to pick what they focus on. So they pick focusing on the new hard thing that they're trying to do. And that means that children with complex health care needs are not the priority in the current discussion. And just to remind us, you know, we saw that nice graph that showing the kids coverage has gotten below 5%. But if you look at where adults were in 2012 in this health affairs article, you can see that non-elderly adults were at about 21%. So that's a huge lift for our state Medicaid agencies. And as we're thinking about how to work with them as practitioners, we have to keep that in mind, that we need to focus our children. That's our job. That's what we do. But we also have to know this is what our partners who we're trying to work with are going through, that the focus of policy right now is on adults. And that's probably going to be true for the foreseeable future because this new expansion is a big deal out in the world. The consequence of that is that alternative payment models aren't designed with children in mind. And this is one of my favorite pieces of pie. That big circle is the entire healthcare spend, which at least in 2011 was about $2.7 trillion. And the little blue slice is all of child health spending. All of it. That's the NICUs, that's the PICUs, that's the home health, that's behavioral health. That's what we spend on child health. So we're 25% of the population, we're only about 17% of the spend, as Cindy said. So when you're looking in the current models for how you save money, you look at that big piece of pie, not at the little piece of pie, and that's what happens a lot. The other thing though, so what's going on in the adult health world right now is, and I see this from a lot of different, in a lot of different ways. I work with a lot of family medicine folks and folks in internal medicine, and they are now being moved into alternative payment models that pay them for performance for chronic disease management. Because guess what? As we all get older, we have chronic diseases. I have 3 chronic diseases. How many do I see in the audience? Okay, I do not look like an adult with special health care needs, but I'm an adult with 3 chronic diseases, and I have disease management programs that are being designed and paid for to manage me. In child health practice, chronic disease is a part of it, and certainly for the children with medical complexity, that's a big part. But primary prevention is much more of a factor than chronic disease management, and we need to design payment models that take that into effect. That in adult medicine, they have some very, there's folks with diabetes, there's folks with hypertension, there's folks with congestive heart failure. Those are large populations, and you can design payment models easily around that. We have small groups of idiosyncratic diagnoses that make up this mix of children with medical complexity, and that's much more difficult to do. The third thing is that they have short-term outcomes they can focus on. They focus on hospitalization and rehospitalization and the prevention of death and the prevention, adding quality life years. Those are measurable things that you can do. What we're trying to focus on is maximizing the arc of a child's development. That takes a long time to happen. That takes a long time before we know what the outcome is, and we don't have good intermediate outcomes to tell us how we're doing along the way. So I want to know how I'm doing as a pediatrician. I have to wait about 20 years to see how the kid's turn out. The good news is I've been in practice long enough where that's happened, and I cherish every time I hear from one of my former patients. I got a lovely email the other day from a kid from a very complex family who is now a research scientist in biochemistry, PhD biochemist, who thanked me for talking science with him every time he came in for a well-child visit. And yeah, I was like, okay, good, I can stop now. That's all good. But you know, we value these long-term outcomes that we see as pediatricians, but they're not captured in the alternative payment models that are being proposed. And then my greatest fear, and you know, I'm part of a number of initiatives that are proposing to demonstrate shared savings in the course of doing this work. If you could really look at the ACA carefully, a lot of the financing for the transformation of the healthcare system is supposed to come from share savings. And it's really hard to generate share savings when you have a small piece of the pie. So I just have to put that out there. That's the challenge that we're working against as we work in this environment. Then we get into the question of measures. And I have to say that the current language is good in that it says we need to measure outcomes, and we all think that's important. I sat last week with a number of people in this room on the first National Quality Forum panel on pediatric measures, and we reviewed 15 pediatric measures, and we approved, I think, 7 of them, if I remember right. We got new measures coming, people. That's exciting. But because the problem is that the existing measures that are out there don't reflect the needs of children. There's a wonderful argument by my colleague, article by my colleague Chris Stilla, who's out in the audience as well, from about 7 years ago, I don't know, 2009, 2010, that put forth this idea that there are 5 Ds. There are 5 things that are different about children and need to be reflected in the measures that we develop for children. They need to reflect developmental change, so they need to look at the life course outcomes with multiple inputs. They need to reflect the fact that children live in dependent relationships. Children are part of families. So you need to include families in everything you do from the ground up. Again, one of the things I'm very excited about for this meeting, that we've done that. But we need to do a better job of that in all the rest of the work that we do. There's a different epidemiology in children, and that epidemiology needs to include a focus on behavioral health, mental health, and school function. That's different than the way we think about adults. There are different demographic patterns. Children are more diverse than adults because guess what? All of our immigrants come here, and when new folks move to the country, they have children. And so we have our younger population tends to be more diverse than the older population. And we also need to account for the fact that 25% of those children live in poverty. And we all know that poverty takes everything that's happening at a biological level and moves it to a different place. And we've all seen that. And this gets back to the point I made earlier. The dollars flow differently in child health. A lot of the work, very little of the work actually gets done in hospitals, although it's a lot of the expense. The bulk of the work of child health care happens in the outpatient setting, and our dollars need to reflect that. And we probably need to incent change with something more than shared savings dollars, because as I said in the last slide, there aren't enough of them to be able to incent the kind of change that we need to see. So I wanted to put the 5 Ds out there. I kind of alluded to this in the previous slide, but the other factor in child health is that behavioral health needs are omnipresent and generally under-recognized and underfunded. I shock people every time I put this graph up. ARC has been doing this now for, 10 years or so. They look at the total expenditures on the 5 most costly conditions in children. Mental disorder have been winning for the last 5 or 6 years. So we need to not carve mental health care out of the care that we provide. We need to bring it back into that care. And as you heard from Cindy, there's a lot of ways in which we've set up the payment system to keep us from doing that. So how do we, trying to move back into integrated care, I think is critical to the work, but there's huge barriers at both the federal level and at each of the state levels going forward. And then there's the fact that this is a state-by-state process. We've got 56 different state territory-based health service ecosystems with variations in managed care penetration, a variation in the relationship between CHIP and Medicaid, a variation in what the essential health benefits look like on the marketplaces, variation in the relationship with Title V and the Vaccine for Children programs in each state. So essentially, we've got 56 different healthcare systems we're trying to do this in. And that is hard work. And it's especially hard work So my practice in Massachusetts, where I worked for 21 years, was on the border of the state of Massachusetts. I had to drive, and I lived in Rhode Island, and I used to drive through Connecticut to get there. Okay, I had patients from all 3 of those states. That's 3 different state Medicaid agencies, each of which had a different set of rules, each of which had different sets of coverage. And I know lots of us face that kind of challenge every day. And families that would move back and forth across the border because their grandmother lived on one side and the mother lived on the other, and sometimes the child was with one and sometimes the child was somewhere else. Very, very complicated. And then within each of these healthcare systems, there's a lot of churn going on right now. I don't know what it looks like everywhere, but I do know in Colorado and in Massachusetts and Rhode Island, there's been hospital consolidation, practice consolidation, the development of these clinically integrated networks. Who can you see? It becomes very problematic. Outside, along with all of that, our academic health centers and our federally qualified health centers are trying to figure out where they fit into all of this because they each have their own dynamics that are driving change within them. And then we have health plans that are developing multiple sets of poorly aligned metrics for payment, which is really stressing the analytic capacity of the practice. If you have to come up with 3 different measures of what your immunization rate is because it's defined differently by 3 different health plans, that's a huge workload for a practice. So that makes all of this really hard. Okay, have I got everybody depressed now? Okay. This is hard work. So where I usually end my upbeating talk, when I talk about this stuff, is to remind us all that the most important thing we can do is to be at the table. And I got to thank Ed for setting such a great table for us all to be at, because we need to be here to assure that the needs of children are not forgotten. But as we're doing this work, we need to think about that in the context of where this work is actually happening at the state and local level, where there are a lot of pressures on the systems right now, and what we are building needs to be able to fit into that. We all need to learn how to measure process and outcomes. We all need to develop our analytic infrastructure. We need to develop the capacity to coordinate care. We need to have our partnerships with behavioral health and others in the organization there. And we need to not forget what we're about, which is taking care of the kids. So from a practitioner's perspective, I think Cindy did a great job of summarizing where we are. I do think there are a lot of promising programs. I didn't talk a lot about them because they told me I was supposed to do 10 minutes, so I cut all of those slides. But there are a lot of promising programs, and we can talk about those during the discussion period. But I think the most important thing is we need to think about how we are going to move those programs forward in this kind of environment that we find ourselves right now. Thanks.
Thanks. So David, I don't think you were depressing, but I'm really going to, I think, spring off where David left off and hopefully leave you with a note of hope about how some of these new payment models can be resources that you can tap into and leverage to really advance the agenda of pediatrics in general, but in particular children with complex healthcare needs. So just one quick note. An additional credential that was not mentioned in my bio is that I also happen to be the parent of a 19-year-old with autism and IDDD. And I have to say that that experience is probably far more relevant and meaningful than all the medical training in my 16 years of managed care. It has really enabled me to move into my role in Medicaid with a very different perspective and one that I try to bring to my work every day. So, you know, I not only talk the talk, but I walk the walk every day. I'm not going to go through all of these slides in detail, but I do want to highlight and emphasize some of the points that both Cindy and David brought up. So this is where we are today. This is the depressing part. So this is the status quo, and you can read all of these individually, but what I do want to highlight is that, as Cindy was implying, this system is no longer sustainable. A system where we pay fee for service, emphasizing volume over value. I think everybody recognizes that this is no longer a sustainable system. And if you could imagine how fragmented the system is for someone like David highlighted, an adult with a couple of chronic conditions, just the challenges of coordinating care between primary care and specialty care or across specialists. Imagine what it is like for a child with complex health care needs, not only to coordinate between a PCP and the specialist or a cross-specialist, but the additional layer of coordinating with behavioral health providers, coordinating with long-term services and support providers, coordinating with human service agencies and state agencies, often cutting across multiple state agencies, coordinating with school systems, and the list goes on. I often say that sometimes what I need more than a care coordinator is another wife, or a wife for myself, because the burden invariably always falls on the parent, most often the mother. Yes, fathers are great also, but disproportionately, data have shown that the burden falls much more frequently on the mother, many of whom often have to take themselves out of the workplace in order to coordinate the care for their child. So again, I'm not going to dwell on this. Like you heard from Cindy and David, it doesn't really matter what the specific numbers are, whether it's the 20/80 rule or the 10/90 rule or the 5/95 rule. We know that both disabled children and adults account for a disproportionate share of the spend relative to their membership. But I think what's even more important to remember is this isn't just about the savings and the money. This is also about enhancing the quality of life for these children as well as for their parents. So what I do want to take a minute to talk about is where we're moving with alternative payment systems and new care delivery systems, because folks, the horse has left the barn, and I think all of you appreciate this and recognize this. And so I think the message that I would like to convey is, how do you latch onto these models, and how do you ensure that they're designed with the pediatric voice in mind, in particular, the voice of the child with complex health care needs. Now, we were very fortunate in Massachusetts. We were one of the CHIPR grant demonstration states. As a result of this demonstration project, we developed a coalition called the Children's Health Quality Coalition. It's a phenomenal multi-stakeholder coalition of individuals across all segments of Massachusetts, including payers, providers, families, academicians, policymakers, and much more. And this group has really been extremely active and vocal as we have rolled out some of our alternative payment models. And their input was really, really valued and had a significant impact. In fact, as we were rolling out one of the alternative payment models that I will touch on briefly, they requested a special session with our state Medicaid program to talk about the design and the quality measures for this program. And I can tell you that I see some heads shaking in the room. Some folks were involved with that. As a direct result of their participation, we significantly modified some aspects of our primary care payment reform initiative. And it really was extremely valuable, and we took their input seriously and were able to implement many of the suggestions they made. So as David was saying at the conclusion of his talk, please do not be reticent. Please speak up, and please be an active participant in your respective states. So for those of you who are not familiar with alternative payment models, I'll just quickly mention that probably every state is somewhere moving along this spectrum. At a minimum, most states are trying to think about how they move away from fee-for-service to systems where providers are taking on more of the risk, ultimately moving towards global payments or bundle payments or ACOs in the purest form. And as we see practices and providers and hospitals and health systems taking on more of the risk, ideally we'll also see greater emphasis on care coordination and managing across the care continuum. Okay, so I'm going to use our primary care payment reform initiative as an example of an alternative payment model and a new care delivery system that really tries to address some of the needs of children with complex health care needs. This particular initiative was started just about 2 years ago, so we're wrapping up the second year of this 3-year initiative. And this initiative takes medical home to the next level. So it's based on a medical home centered in the primary care practice, but really pushes the envelope, particularly on promoting integration with behavioral health. So there are three key elements to our primary care payment reform initiative. One is a comprehensive care payment. This you can think of as a bundled payment for all the services that fall into a primary care practice. So all those things that pediatricians historically could bill for under fee-for-service. But in addition to that, we offer them an add-on payment, a medical home activity payment, which is to enable them to build that infrastructure for all those services for which pediatricians traditionally could not bill. So for example, all the coordination of care, all the administrative work, supporting prior authorization requests, the coordination with specialists, the coordination with school nurses, with human service agencies, and other sorts of infrastructure that would enable them to really coordinate the care effectively of children with any medical needs, but particularly for children with special health care needs. And there is also an add-on payment based on one of three different behavioral health tiers that the practices can opt for, and I'll reflect that in the next slide. And then finally, there are some additional payments. There are some quality incentive payments for meeting certain quality gates, as well as an opportunity for shared savings. So to David's point, it really is important to remember that for children in general, pediatrics are not expensive kids. They're not the ones who are necessarily having the frequent hospital admissions, although they will often have frequent ED visits. And so it's important as you think about alternative payment models in your state, think about where the potential is for pediatricians and primary care providers to leverage the financing and the resources under these models in order to effectively put in place the infrastructure that would enable them to and incent them to manage these children and conduct care coordination and the types of things that all of you would like to do but often are not reimbursed for under a fee-for-service system. By the way, just some data on our primary care payment reform initiative. It is not mandatory across the state. We did have an RFA process. We have 28 provider organizations comprising 62 different practices participating in this, covering 90,000 members. About 25% of the members in this initiative are pediatrics members. So, as I mentioned before, practices are required to opt for one of three different behavioral health integration tiers. At the most basic level, under Tier 1, they are required to have a memorandum of understanding or a written agreement with a behavioral health provider to coordinate care and integrate medical and behavioral health care. Other things that some practices might do under Tier 1 are things like doing some very basic lifestyle management coaching. In Tier 2, there's a requirement for actual co-location of a master's or doctoral level behavioral health provider for no less than 40 hours per week. The practices have to be able to schedule the first available behavioral health service appointment within 14 days from the time of request. And at this tier, there is a requirement to engage in more active screening and assessment, particularly for things like substance abuse, behavioral health conditions, and to provide some additional behavioral health education and lifestyle management. And then finally, at the highest tier, at Tier 3, there's a requirement for a co-located psychiatrist for at least 8 hours a week and 24/7 access to a behavioral health provider. So I want to focus for a minute on this next slide because I think this is where I hold out hope that some of these alternative payment models can really promote the kind of coordinated care that we need to see for our kids with special health care needs. So the beauty of these types of designs, and particularly our primary care payment reform initiative, is that it does not limit the physician to the fee-for-service system, and it incents them, if designed appropriately, to really invest in that infrastructure that we were talking about. So one of the beauties I do have to say about our primary care payment reform initiative, and by the way, we have gotten terrific feedback from our providers in the community who are participating in this initiative, is the flexibility that we have afforded practices. And oftentimes there is a tension between trying to be prescriptive and mandate a certain number of elements or requirements versus the desire to be flexible. I think we found a really great middle ground in offering a lot of flexibility to the practices. While we do prescribe certain elements, such as the requirement that every practice have a care coordinator, we also recognize that it's not a one-size-fits-all situation, and we could not see taking a cookie-cutter approach to every single practice. And the reason for that is multifold. Some of our practices are urban practices, some are based in rural areas. Some have kids with very different populations. As David was saying before, the group of kids with special health care needs represents a very heterogeneous group. And so we wanted to afford the practices the flexibility to best serve the populations that they are treating. And so for some practices, they have used some of that medical home activity payment to hire peer supports or parent supports. Others have invested in community health workers. Some are experimenting with telemedicine and telehealth. The bottom line being that we feel that the primary care providers are at the point of care. They know their populations best, and we wanted to make sure that we could afford them as much flexibility as possible to reach their patients where they work and live and play. So one other advantage of our design was that it was risk adjusted, and we frequently get concerns expressed about how some practices that have particularly sick kids feel that they might suffer under some of these models. Fortunately, we have some really smart people who have figured out and continue to work on the risk adjustment, but it's a really important component to reassure practices that that they will be adequately compensated to manage this pool of patients. Okay, so I'm not going to go through all the quality measures. I do provide the slate of quality measures for our primary care payment reform initiative, but a really important point that I think folks need to keep in mind, a lot of times we focus on the quality measures and having appropriate quality measures in order to make these programs work. I do want to remind folks that there are other levers that we can also apply to ensure that practices are putting in place medical home models that are effective. As an example, there are contractual mechanisms that can be used. And so in our contracts with the practices, there are certain process measures or certain elements that we required along a certain timeline. For example, as I mentioned before, having a care coordinator. In our model, we also require having an integrated care plan, putting together a multidisciplinary team for initially for high-risk members, but ultimately for all enrollees, ensuring that the behavioral health integration piece is put in place and having access to the behavioral health providers. Other states are also looking to certify either medical homes and/or ACOs. We are actually embarking on a certification process as well in Massachusetts, and we expect regulations to be promulgated shortly around ACOs. Again, we're trying to be very mindful of what sorts of elements we would like to see as a requirement for an ACO to form. Again, trying to balance being prescriptive for some elements versus affording some flexibility. And then finally, I mentioned before, we do have a number of quality measures, and I'm happy to report that, again, as a result of an extensive stakeholder engagement process, not just with the Children's Health Quality Coalition, but with a number of other public stakeholders, I think we struck a really good balance between adult versus pediatric measures, and then obviously some measures apply to both. One of the concerns that we had is that, as I said before, we'll never be able to rely solely on quality measures for a number of reasons. Many of the measures that we're looking to introduce or the elements that we're trying to advance in these models are not necessarily conducive to quality measures, at least not today. For some of the measures, especially the process measures, we often lack valid and reliable nationally accepted standards, particularly as we move into areas like long-term services and supports. In other cases, some of these measures are extremely burdensome, either for the provider or the state or the payer, if other payers are involved, to collect. And there are certainly limitations. We haven't really spoken about electronic medical records, but there are significant limitations to the amount of information we can collect and extract from those in the present state. But we continue to work around developing measures, and as we move into ACOs, we are currently actually in the process of a whole stakeholder engagement process around ACOs. We're focusing a lot of attention on how do we develop measures around individuals, including the pediatrics population with complex healthcare needs. Ultimately, though, our goal is to really come forth with a new care delivery model that really addresses all of those concerns you saw in my initial slide about the status quo. So really trying to be thoughtful about how we design alternative payment models and care delivery systems that really put the patient at the center. So patient-centered care, invoking a multidisciplinary team, and really ensuring strong care coordination and care management. So finally, I just want to close by mentioning some pearls that we've learned as we've rolled out some alternative payment models and as we think about rolling out ACOs, and ways that you can be particularly effective in your roles around ensuring that these models really promote the care of children with special health care needs. Any good model should expand the medical home model, and we really, we had a patient-centered medical home initiative prior to embarking on our primary care payment reform initiative, and we chose to really focus the PCPR initiative on the primary care practice with a strong behavioral health integration component. And the reason for that is because even though we suspected that ultimately we, like many other states, would be going the route of ACOs, we really felt that the medical home was foundational to any alternative payment model. And so we have expended a lot of effort and thought in trying to design a model that would really bolster the primary care practice and the medical home to ensure that we're promoting strong coordination of care and care management. Not just, again, as I said at the outset, not just between primary care and specialists, but also between the medical world and the behavioral health world and the long-term services and support world. And as I said before, really trying to strike a balance to offer flexibility to the practices so that they are able to meet the unique needs of their special populations. As I said before, alternative payment models can ensure the adoption of medical home elements, not just through strong quality measures, but also through certification requirements where applicable in your state, as well as contractual obligations. And just bear in mind, I think it's worth remembering that process measures that improve pediatric care often improve adult care and vice versa. A good example of this is around obesity. Incorporating measures around childhood obesity not only help the children, but also often have a spillover effect to the parents. And finally, I can't emphasize enough the value of stakeholder engagement. It is really critical, and as I highlighted before, really can be impactful. So please don't be reticent. Make sure you get involved with the different initiatives going on in your state. Most state policymakers really want to hear your voices. And it's also important, I think, I too applaud Ed and the foundation for getting this group together. There's so much that we can advance through learning collaboratives. We have had learning collaboratives as part of every one of our state initiatives, and there's so much value just to bringing people together and sharing lessons learned. So thank you. I know that was a quick rundown, but I'd be happy to answer questions during the panel Q&A as well. Thank you.
Well, first I'd like to commend my panel members for keeping very closely to time. That was terrific. Nobody had to deal with yellow and red lights, so that was great. And really, the floor is now open for discussion. I think really look for your questions and comments. I think we have enough time that we can allow comments, but preferably if they're also have a question attached to them. And please, their microphones, I think if you would just come up to the microphone, we could just launch right in.
So I guess I got here first. I'll start. David Labby from Health Share of Oregon, large coordinated care organization focused on Medicaid. And I wanted to respond to David's comment about how it's actually a pediatric narrative that I've heard for many years. You know, we're 25% of the population. We only cost 17% of the cost. Nobody cares about us. You guys are only interested in adults. Well, our experience as a CCO, as a accountable care organization, really started with that narrative. When we started, we focused on adults. And what we found when we looked at the complex care adults is they actually all started off as kids. And in fact, they not only started off as kids, but they started off kids with really troubled lives, and their start with adverse childhood experiences cascaded into school failure, into health failure, into marginalization, into drug abuse. We all know this. This is what happens. And so now, one of the major strategies of our CCO is actually focusing on kids and identifying early identification of kids and families at risk, and what can we do about that? Because we know that those are the kids who will become the high utilizers, and we know that we have 30 to 40 years of kids who have already become young adults in the pipeline that we will have to deal with. Why do we want 50 to 60 years of that? So it's become really salient. And then the more we thought about that, and the more we had experience with that, we said, well, you know, one of our CCO metrics for which we get a quality payment is around developmental screening, right? And so if we're just screening, well, there's lots of problems with screening and the referral once you find something, but really, shouldn't we be doing something upstream of that to say, well, maybe there's something we can do so kids don't need help? And there's also conversation about maybe kindergarten readiness ought to be a CCO metric. So I think there's a huge opportunity for the pediatric community to change its narrative. And I'm really asking you to change your narrative. Quit saying that. Start saying, the kids that we see are the kids who will become your high utilizers unless you help us make that not true, right? That is I think there's an opportunity nationally for that to be really salient, right? And the second part of this, and I'd be happy to talk more about that. But the second part of this is we understand now that really we have a two-generation problem. And I think that's the two-generation problem around kids is the fact that one of the biggest social determinant of health for kids is their parents and caregivers. And if you look at the data around, as I have recently, around children with special health care needs, stressed families have more problems for their kids, and their kids have more problems. So unless we put into this framework something around a two-generation approach, which actually makes you ask the question, well, how do we help the parents help the kids? It's not just the parents need training around care coordination. They need help with mental health issues. They need help with respite. They need help with substance use. They need help with unemployment. And we can't deal with that problem sufficiently unless we deal with across the continuum of care. So I'd like us to expand our view of this, that this is not really just a pediatric problem. This is a health system problem, and the system of care for children with complex health needs actually needs to be a system of care for a larger population.
So, David, thank you for those comments, but let me maybe frame those a little bit as questions for my panelists, which is, so EPSDT's been around for a long time. Why has it been able to? Why aren't Medicaid systems ably addressing some of those broader social determinants? And similarly, what can we do to national Medicaid, CHIP, and payment redesign policies to address some of the issues that David's raised?
So first let me say that I think the idea that nobody cares about us, I absolutely agree, should not be our narrative. And I use that, though, as I think it's important for us to understand where the person we're talking to is coming from. And certainly, I think as Medicaid agencies grapple with the problems of the newly found adult population, I think that is their primary concern right now because of a bunch of reasons, including the short-term high costs. That having been said, I think that expansion gives us exactly the opportunity that you spoke of, because I remember hearing an interview with the head of the British Health Service talking about why are you investing so much time and energy in child health, and he said, because I take care of these people until they die. And so I know that if I don't invest the money now, I'm going to have to pay it 40 years from now, and it's all the same system. So again, the closer we get to a unified system, the more I think that argument holds weight. And I think that's absolutely the way to do is for us to be pointing out that we have the opportunity at the beginning of the life course to alter things that are going to change the end of the life course. And I think that's a really important point. So thank you for that. The second question, Charlie's question as he framed it, as to why hasn't EPSDT worked, I would submit that T is my favorite letter in the English language. And if for all of those of you who have not been using T as your sword and shield as you go forth, I'm very careful to point out to lots of people when I'm teaching this stuff that Medicaid is the only insurance in the country that is held to the standard of EPSDT, that private insurance is not held to that standard and is therefore less good. And there was a recent paper by David Rubin that just came out from CHOP where he looked at now I think it was the National Health Interview Survey, but check me on which survey he used, but looked at parents' perceptions of insurance, and they very clearly said that Medicaid did a better job of making sure that their kids got what they needed than private insurance does. So I think that T should be our favorite language and the sword in which, actually the other thing I noticed is that if you look at what EPSDT stands for, it's grammatically incorrect. It has a comma in the wrong place. But nobody will ever change that because that would involve changing legislative language, and nobody wants to mess with the possibility of deleting that T. So just, I think it has been effective when it's been used. I think that what we heard from Cindy is that it's not always used, that people don't always understand it. It sometimes takes tweaking to get it right, and that's our point of advocacy.
I will just add a couple of comments. One is it was a very wise Medicaid director who once said in a forum many years before the ACA, if they would just let me cover the childless adults before I get them as people with disabilities or the elderly, I could save a lot of dollars. So, and it's obviously true if we could affect that trajectory for a child. The issue that we all know is that budgeteers have a much smaller window than the lifetime of a child, or and in terms of trying to find those savings. And we have had a system of managed care and delivery of care that has not taken the stand of the British health system, which is they're mine for life. It's like, oh, they're mine for now. Which is why I think the continuity of coverage and continuity of care and the alignment of across marketplace in terms of plans and providers staying with that child is so important in terms of not just better care, but also that sense of responsibility and that sense of obligation for the child's well-being for a longer period of time than potentially between one recertification and another. I think Charlie's question also raises the issue of what other kinds of services do families need that isn't necessarily covered by our healthcare system. And there's been a lot of conversation going on, I'd say, in the last couple of years around what can we do better around in our healthcare system around recognizing the social determinants of health, and how can we effectively leverage the services that are out there. And I think it's early. There's a lot of experimentation going on. So a lot of community-based organizations and healthcare systems getting to know each other for the first time. But we will also find, sadly, that there are gaps in financing. Once we've discovered how important housing is, for example, for a family's well-being, we will quickly find out that there's not enough resources out there to assure that there's affordable housing for families, and that the stress from eviction is not necessarily something that we can, even if we have our antenna up, that we can always avoid. So it's good, though, that we look at all of this. There are opportunities to leverage what is available, and there are new opportunities if you look in the Medicaid managed care regs that CMS issued as proposed, not final. They've recognized a concept that's sort of been out there but not really written down of in lieu of services, whereas in a managed care setting under a capitated arrangement, you can, under federal Medicaid law, use some of that capitated payment to say, and the famous example often cited in Oregon is, I can buy the air conditioner instead of having that asthmatic kid continue to show up in the emergency room. So I think there's opportunities both to make linkages with resources that are out there. I think there are opportunities to be able to think about how to finance some of those services. And there's also going to be gaps in those services for families that we all need to pay attention to, and what better voice to fill those gaps than families with kids with special health care needs and their providers.
I'll just quickly mention, I'm glad, Dr. Labby, that you brought up social determinants of health, because risk adjustment obviously doesn't factor that in. Risk adjustment's looking at age, gender, morbidity. And so we've given a lot of thought to the impact of social determinants of health. It's not an easy science. It's hard to know which social determinants specifically are most predictive. But we are very concerned about the impact of social determinants. And so while we don't foresee necessarily making ACOs responsible for providing housing or arranging housing or other sorts of resources, there are some ways to think about tying ACOs to community resources, and perhaps even writing in requirements that ACOs have referral patterns to some of these social agencies, and try to build up those partnerships. So we're thinking about ways that we can continue to foster and promote those partnerships so that they will access services that are existing in the community. But you're right, Cindy, I think as we get into this, we will find that there's some gaps.
Yeah, well, actually, I'm elated that the first presentation or question actually focused on...
Just introduce
Sure, I'm Jeff Goldhagen. I'm with the University of Florida in Jacksonville. And so I'm excited that the first question had to do with social determinants of health. And in other venues, I seem to be one of the few people that are up ranting and raving about the fact that children spend a small amount of the time in hospitals, even in small amount of time in outpatient centers, an enormous amount of time in schools and communities, in their homes, and so on and so forth. Yet, again, it's like the saying, if you have a hammer, everything looks like a nail. And so if you're focused on hospital-based care, if you're focused on decreasing the cost because of outpatient centers and outpatient clinics in those environments, you forget about the rest of the world where the enormous opportunity is for savings and where people and families would prefer to get their care. Now, having said that, the other aspect of this is this whole new discipline, although it's not so new, of palliative care. And in fact, we have now a huge amount of focus on palliative care. We have board certification in palliative care. The focus in palliative care is dealing with issues out in the community. It is using interprofessional and integrated systems. And so, in fact, we have this system in place, but we're not talking about it. We're not asking the question, how do we engage this whole new discipline, this whole new movement of palliative care, and with hospice at the end of it, but in particular for children, if you have a hospice and palliative care program, 95% are going to be in palliative care, dealing specifically with these kids, and maybe 5% in hospice care. In Jacksonville, we have amongst the largest, I think, most sophisticated in the country. And I can tell you, because we've looked at the data, the cost savings in hospitalizations, the cost savings in DME, and the improvement in health-related quality of life comes from the palliative care program delivered in the community and not from the services that are provided in the hospital and in the outpatient clinic, although those need to link directly to that other system of care. So I would, in final, sort of frame it as a question, when you've looked at your cost models, did you look at all of those other issues, whether it's therapeutic daycare centers, whether it's respite care, whether it's transportation, whether it's indirect costs because mothers have to take time off? Have you looked at the total cost of what it takes to care for these children and not just really focused on the outpatient and the inpatient cost of the care? And I'm excited there are some other people in the audience here who come from the palliative care world and would, over this next day and a half, love to hear their perspectives on this as well. And I'll take the answer offline.
Yeah, well, I'll just say I think you raise an excellent point, and you know the one of the challenges we have is that we tend to work with what we can measure, and what we can measure right now, at least from our all claims paid payer database, is claims paid and cost to parents in the extent at which it's comes out of the deductible. So we are limited in what we can do with statewide data, at least in Colorado. That having been said, it's of critical importance to us to try to capture that, and we've actually, within our Colorado Sim project, we've actually set that as a goal to try to capture something that's more like total cost of care from the parent's point of view in the course of doing that work. We're wonderfully open to ideas about how to do that, and would look forward to talking with you about it.
Hi, Simon Hemage from Denver. I had one comment and one question. The comment was around other special populations. I think one other significant population that we need to think about are refugee children, who tend to have a higher percentage of medical needs and social needs both, and behavioral health needs, and can be very challenging, come from very different backgrounds. The question is really directed to the Massachusetts experience, and you know, Massachusetts has led the way in many ways for payment reform, but I didn't hear a lot about the sustainability of that program. It sounds wonderful, it sounds great. Are you seeing enough cost avoidance to keep it going?
Yeah, so as I mentioned, we're only wrapping up the second year, so it's really too early to tell. We are currently, as I mentioned, embarking on a whole stakeholder engagement process around ACO, so we're looking to really roll out on a broader scale. We are optimistic that we will see both an improvement in quality as well as lower costs. Again, too early to tell, but we have some experience from other states that we're looking to as well. So too early to tell, but
Stay tuned.
Stay tuned.
Okay, thank you.
Hi, I'm Eileen Forlenza from Title V in Colorado, also the incoming president of AMCHIP, the Association of Maternal Child Health Programs. I also serve on the National Center for Healthcare Transition for young adults with chronic healthcare needs transitioning into adult care. So I'm heavily invested in this conversation as a parent of 4 kiddos, all of them having their own unique set of needs, but primarily my second oldest, who has been navigating the healthcare system for 26 years now. So I have a couple of comments. One of the pieces that is similar to the community-based healthcare, but we have a huge gap in coordinating our system with education, the education system. We know that where the buck stops in terms of measurement and federal accountability is our education system when it comes to how are our kids doing 2 years post-graduation in terms of their own independence and independent living, health management. So I'd like to know if there's any work being done at the federal or even some state levels. We've had some great progress, I think, with the CHIPRA grant related to the school-based health centers, but nary the two shall meet once again, and I'm not sure that the communication is being held to families. Also, I would like to comment, David, to your point about EPSDT. The word among the families has always been, yeah, EPSD, and it stops at T. There's no access to specialty care for our kiddos, and the treatment just continues to fall behind. So one of the pieces that I think is important, and Rich and I have worked together on this for a long time, is considering families as a critical part of workforce development. And that what we've seen, pardon the brassness of my words, but I feel like a lot of the care coordination work that families have been doing for years has now been hijacked by other systems, and now it's billable. And families have been doing it for years, and yet now families continue to be a horizontal thread across all these vertical systems, and yet we haven't included families as part of that workforce whose services can be billed. And I think that's a gross inequity in our work and the time that we have spent in trainings and credentialing and going through patient navigation training, and yet there's no way to embed us in the system to be paid for the care coordination services that we currently do. So in terms of your discussions around alternative payment systems, I'm curious if there's been any discussion about that. And then let me check my notes and make sure I didn't miss anything on behalf of all of the awesome family leaders that I'm chatting with. Also, I don't want it to be left, unfortunately, Colorado is taking on a sad recognition of being a state with a lot of gun violence. And I just want to point out that we are raising an entire generation of children with PTSD and an entire generation of children who can't get a grasp on what safety really feels like. So again, from a federal and state perspective, I just want to be aware of how important the gun safety, without getting overly political, but that on behalf of children, to understand the mental health needs that are coming in now as a result of simply the reality of what we're dealing with. So that's all my questions for now. Thank you.
Health and education, looking at outcomes. But I can certainly say we've had joint policy statements between the health and education on the early childhood arena, and the issues around inclusion has certainly been an area where there's been a great deal of work and effort. There's an interagency policy board, which I do happen to sit on, that does, particularly in the early childhood space, is very focused on these issues of coordination, integration, and having common metrics, and making sure issues around inclusion are critically important in all early childhood education settings and programs. I am less expert on things looking at how that applies to, for example, high school graduation and college scores.
So I'll give one shout out to my friend Paul Dworkin in Connecticut, who has done wizard work with the role connecting early intervention to kindergarten readiness, and has established a uniform standard of assessing kindergarten readiness across the state, and is using that as an outcome. But I hear you, that I think that the connection between the education system, and whenever anyone asks me what my favorite outcome would be, for a well-functioning child health system, I always say the high school graduation rate among my patients. And I don't have a way of measuring that. I just have a way of applauding it whenever it happens. And I literally do, when one of my patients graduates, applaud for them. Because I think that's critical. So that's clearly an area of policy that we need to work on. I don't know other places around the country that are able to bring that kind of data in. I think in Colorado, we're thinking about it as part of the Colorado Opportunity Project, but I think that's still at the thinking stage.
You know, national education policy has become toxic, to be clear. So, for example, I think this is public knowledge that, for example, even the preschool development grants is being awarded to Health and Human Services, because certain parts of Congress don't want the Department of Education to be dealing with anything like this, because they're so unhappy with the Department of Education. So it's an interesting, I'm relatively new to Washington, and so this experience of how these things play out is quite intriguing. So it would be helpful actually to hear some of the metrics and things you might suggest, and coming from the health side, it might have an easier time getting through than having it come through on the education side. I don't know, Cindy, if that's been your experience.
That Washington's toxic? So I actually hadn't even heard of the kindergarten readiness as a metric, but I had scribbled it down when it got identified, so I do think it's very intriguing. I just want to point out, which is smaller scale than I think that what you're talking about, but there have been, I think, inroads around deepening the school-based health services and trying to make sure that they are connected to the child's family, and which is usually the case, but then connected to the child's primary care physician, so that there's some continuity of coverage. I think is a lot of some of the struggle. There's issues around privacy, and that sometimes really difficult to get through in terms of what the education rules are versus what the healthcare rules are to get some level of exchange of information. So that's something that needs to be worked on. We did at CMS issued new guidance. We issued guidance. It's not that new anymore. It's maybe a year or so old around. It used to be the case that if a school was providing a service to a Medicaid beneficiary that was a Medicaid reimbursable service, that it couldn't bill to Medicaid because it was providing it free to other children. So it was the so-called free care pool rule. We got rid of it. Said that's crazy. If it's a Medicaid benefit and it's a Medicaid beneficiary, you can charge for it. So it does. I'm not sure how widespread the information about that financing opportunity has been, but it does open up opportunities to increase the financing pool for the provision of healthcare services at the school level.
Just wondered if we could also have a comment on this issue about whether family providers of care coordination services will ever be able to bill, whether we're looking, for example, caregivers on the Medicare side. Are there any other things both either on the Medicare or Medicaid side that enable family caregivers to get
Well,
paid?
family caregivers can be reimbursed on the Medicaid side for home and community-based services. It's a largely state decision, not driven by federal rule, and a lot of states have moved in that direction. I'm not as aware of that happening on the care coordination side as opposed to the actual provision of the in-home supportive services, but my guess is that may be moving in that direction, but I haven't really heard much about it in that direction. But we have such a shortage, such a workforce crisis. It makes a lot of sense, and I think as was mentioned, we have family members who give up their ability to bring in income because of the demands of taking care of their kids, and so needing to recognize that economic reality for families, I think, is really important. There's nothing in federal law that will prohibit it. It's really about licensing, certification, and rules that a state comes up with.
So just two things. I just want to quickly touch on the school-based services. We are fortunate. We do have a number of schools that do take advantage of the program that Cindy was talking about. In addition, there are pockets of other services being provided by outside healthcare providers, not just school-based providers. But to your second point, I think it's a really important point. And again, I would encourage all of you who are going to have an ability to impact alternative payment models to think about how family members could be used. And we have seen some practices under PCPR and some other programs hire parents to mostly to provide parent support or peer support to other families, not to actually do the case management of their own kids. But these have been extremely effective. And for those of you who are parents of children with special health care needs, you've probably learned more from other parents than you have from the clinical world. And so I think it's a really important resource for families to have. And so you might want to think about how these new alternative payment models could leverage the parent resources in the practices.
So I'm Francis Rushton. I'm from South Carolina, and I'm the medical director for South Carolina's CHIPRA QI State Demonstration Grant. I really enjoyed all three of your presentations. They were fabulous. But Carolyn's presentation really sort of hit home to me because you've been working on some of the same things that I have. I really like the fact that you emphasize the need for flexibility when you're working with practices around the state of Massachusetts. We've discovered the same thing in South Carolina. When I'm working with a single practitioner in impoverished Cheraw, South Carolina, versus someone who's in a doctor office in relatively wealthy Mount Pleasant, South Carolina, it's very, very different in terms of the resources and opportunities that are there. And I think it's important that we remember to treat the practitioners in all different types of environments as the experts that they really are, the experts in their community and with knowledge on how to move forward. So I commend you for that. I was struck, even though South Carolina is very different from Massachusetts, that one of your major emphasis seemed to be on behavioral health. And that was one of our major emphases in our South Carolina CHIPRA QI grant too, and I think probably the area that we had the most success. But if I heard you correctly, it seemed like you were putting a lot of emphasis on co-location, having psychiatrists and psychologists in the office. And maybe this is a difference that reflects Massachusetts versus South Carolina and us having less resources in South Carolina. We certainly encourage resources, but with our work in South Carolina, we unpacked the American Can Pediatrics Mental Health Toolkit and spent a lot of time looking at referral mechanisms, problems with getting information back from mental health providers and information to mental health providers, finance mechanisms, including going back to our state Medicaid agency and getting them to pay for all sorts of screens and to enhance reimbursement to master's level counselors, office receptiveness to mental health. We started off with having lots of practices who said, not me. I don't want mental health, and encouraging them to take ownership of this is a major problem for kids. New systems in place, such as screening systems, PSC, PSCY, depression screening, postpartum depression screening, social environmental screening, and then point of service support, decision-making support. And I have to admit, in that last part, we stole from Massachusetts and looked at your ability to have a consultant available for practitioners in place. So I was wondering if you could comment about that. And then the other thing that struck me was we had a big focus on patient-centered medical home.
We're getting tight on time.
We started with the NCQA patient-centered medical home process, and that didn't work out very well for us in South Carolina, maybe not as well as it did elsewhere. The components of the patient-centered medical home were great, but the application process was too cumbersome, and the practices that got status had big bureaucracies they were attached to rather than the ones that were really providing care to families.
So just a couple of quick points. So the Primary Care Payment Reform Initiative is one tool we use to foster behavioral health integration. There are some cases where we don't necessarily require on-site physical presence, but a strong collaboration, essentially ensuring that the behavioral health resources will be available in a timely fashion. But the other program to which you were referring, I think, was the MCPAP program, the Massachusetts Psychiatry Access Program. And this is a terrific program. We have gotten phenomenal feedback on this program. This is a telephonic resource staffed by psychiatrists and Barry, you're somewhere here in the room. There you are, who actually runs our program. And the feedback is terrific. When you recall that the vast majority of kids receive their behavioral health care in primary care practices, it's really important to provide the pediatricians with the tools and the knowledge to treat these patients. So that program is used in concert with our PCPR program. But again, it's just another way to ensure access and timely treatment. And then there was one other question you had. Oh, yeah. So we also recognize that while NCQA PCMH certification was the ideal, our practices, first of all, were all over the place. Some had not even started that journey. Some had already achieved level 3 certification. So we did not make it a requirement that they achieve it at the outset. We do expect all of them to achieve it, to achieve level 1 certification, which is actually a pretty low bar to reach. And part of the reason for that is because at the time when we rolled this out, we felt that there were some practices that were already there, even though they had not gone through the process of seeking certification. And so again, we wanted to be flexible and also have some other requirements that weren't necessarily part of the NCQA certification process. But I think the flexibility is key, as you highlighted. And again, we have such a diverse, heterogeneous population. We have many different ethnic populations in Massachusetts, and we felt that practices really knew their populations best and knew how to best reach them.
Richard?
Okay. Richard Pan. I'm state senator representing Sacramento in California, and one of the frustrations I've had as a policymaker is that when it comes to children with special needs, complex healthcare needs, children with special healthcare needs, one of the things when we talk about medical homes, certainly Barbara Starfield talked about the importance of the relationship. And I think I know Cindy Mann just touched about continuity of care, but continuity of care not just with the medical home, or it's also with the care coordinator. We've heard that from families as well. We can have a great system, but if each family has to re-go through the entire history of their child every year because they have a new care coordinator, then they have a new medical home person, and then so forth. So what are we, and I know you touched on it, I know Cindy touched on this, but can you talk more, maybe elaborate more on what are some policy things, solutions we can put in place that actually values that relationship? Because what I see in my work is that basically the agency wants to treat everyone like widgets, and we're all very interchangeable, and whoever's the lowest price is who we're going to contract with. But if we lose that continuity, we lose that relationship, that's the thing that I hear from families more often. In fact, I think when we talk about paying families to be coordination of care, because the family's the one who actually doesn't swap out all the time. And we have a problem there in foster care, actually, where families do swap out, and we have a problem. So what can we do to pay for continuity of care, the relationship? That should have value, because that certainly seems to show differences in outcomes, unless you want to tell me you have research that shows otherwise. But I think that relationship actually it has value, and we should find a way to pay for it, and that we should incentivize ongoing relationships and not just saying that, well, as long as you hit all the checklists on NCQA, you're good. We have a medical home now. So anyway, leave it there.
Quick response.
Very, very quickly, I'll refer you to my Health Affairs blog in 2013 where I talked about this very thing. How do you value the relationship? I think the only way we can value it in the current system is we need to measure it and we need to pay for it. And it can be measured. There are tools out there that will do it. And you can actually even use the caps for some of that if you want. But I think that's the key, is to build that into our payment system so that we value that relationship, which gives those folks an incentive to not disrupt it if you're going to be taking care of this. I think it's hard, but I think it's right.
And, and the other part of, or a part of paying for it is the people that usually do these jobs are often at the lowest rung of the salary scale, and there's a tremendous amount of churning among that workforce. And so I think we need to think about pay structure, we need to think about training, we need to think about retention as well, which then triggers into Medicaid payment rates and whether states are ready to value that in terms of the dollars spent.
So it'd be good if this community, we heard more from the research community about the importance of relationship, because I don't hear very much about it. Thank you.
One last quick question.
Quick, yes, thank you. Thanks for letting me. Lisa Rosignol from Albuquerque, New Mexico. And I just wanted to kind of continue this. I think we're all kind of hitting the same thing. I think that it would be really germane to our discussions here, and maybe it's not something we can resolve right now, but being really clear about the difference between care coordination, care management, case management, because these are all distinct billable activities. In rural New Mexico, we see the same person doing 3 or 4 of these and billing them separately. And ultimately, in the urban areas, we see them being 5 additional relationships that families with children with special health care needs have to then manage, just with what was alluded to. So people I have to be nice to when I'm tired and dirty from living in a hospital room and all that sort of thing. And so looking at that. I like this idea of incentivizing it. In New Mexico, our long-term waivers used to pay a community direct support, but when we went to the 1115 waiver, they did away with that. So now you can hire somebody to do different aspects of all of those, but you don't get compensated that way. So I think two questions, and maybe we can't do it right here, but one is being really careful and realizing that there are a lot of different ideas of what this is. We all think we know, but then we sit in SIM grant meetings, or we sit at PCORI, or we sit in any of these things, and it turns out that one person thinks that it's something that belongs under the umbrella, and another person thinks it's something else. So I think if we're doing systems work, we have to be really clear on what we're defining, who should be doing that, what the capacities are, and then how could parents and families go after that in a monetary way.
Well, thank you very much. Thank you for your indulgence. I did let the session run 5 minutes longer. I cut your break to now only being 10 minutes, but I thought it was important to hear. Thank you. It was a great panel.